Dr. Ayushi, my dear friend. She is going to be talking to us on two cases of post-diabetic TRD related, um, you know, uh, well, three cases maybe of diabetic TRD related challenges. Yes, Ms. And let's see how they were managed. We're running short of time. I'm going to omit my cases. We'll just have Samyak's cases after this so that we can do justice to discussions to both of them, and then we'll be able to finish on time.
Yeah, morning everyone. So I'll quickly take you to 2-3 cases. So this is case 1, 52-year-old male, diabetic for 6 years, on oral hypoglycemics, hypertension 4 years, both eye perception of light. This is the B scan. Right eye has minimal VH, left eye very dense layered VH. Over the next 45 days, I planned the right eye mature cataract surgery. He was ambulatory with 612, initiated PRP. The left eye, the next 3 weeks later, we did diabetic with pre-surgical Avastin. Nothing out of the ordinary, uneventful surgery, very dense old VH, carefully cleared in layers. It was a treatment-naive retina, so around 2,500 spots of endolaser was done. Eye was closed in saline because the other eye after PRP had bled, so just to give him that ambulatory vision. This is POD1. He improves to 618. Anterior segment is absolutely quiet, but the fundus is showing dense transvitreal fibrin strands. Retina seems attached. OCT shows macular detachment. At this point, I started on topical steroids early, did not give any systemic steroids, sugars were high, and routine post-operative antibiotics were continued, oral. None of the patients on the same day had any sort of inflammation in their eye. This is POD2. Again, vision is dropping to 660, but fibrin bands are somehow retracting, but the detachment at the macula was worsening. He wanted to go home, so I sent him off with some Visalon under monitoring of his sugars and 1 hourly steroids. Comes back on POD4, vision is again worsened, but bands are less. But then OCT shows a massive detachment, query serious, not sure tractional, because these fibrin strands were attached on the retina, at the macula, in the periphery, and I could see that the retina was lifted at those areas. So I immediately planned for fibrin removal with oil injection. He was practically monocular at this time. This is POD1 post-SOI. He's improving to 624 over the next 2-3 weeks, uneventful SOR, and he's doing fine. This is the second case, 63-year-old female, DM 20 years on insulin and hypoglycemics, CKD on dialysis for thrice weekly. Right eye is lost to NVG, left eye is hand movement. Undergoes a 25 gauge PP with endolaser under proper anesthetic care. Eye is closed in saline and sclerotomies were sutured. Vision post-op is hand movements. AC shows cells, but there's no hypopyon and there's fibrin on the PCIOL. Posterior segment, there is CDs, exudative RD, and you can see on the corresponding OCT, there is subretinal fibrin. Suspected to have toxic posterior segment syndrome. Half-hourly topical antibiotic steroids were continued, and she was sent for dialysis the next day. POD10, she's not getting better. Vision is still CFCF, exudative RD, fibrin is persisting. So 20 mg of PST is given, and topical steroids are continued. This is at POD 1 month. Vision is 660. AC is quiet. There's dyspallor, and all the signs of inflammation have resolved. I think I have time. I'll quickly go on to another case. This is a case of monocular. Okay, this is another case where she underwent diabetic WIT. It was a treatment-naive retina. That is POD1 here with 360-degree CDs. She was managed only on topical steroids, and she kind of resolved. So these are the 3 cases of the transvitreal fibrinoid reaction you can say over the spectrum. We can discuss this.
Thank you. Thank you, Aishi. I'm going to pose the question to you, and you can be there. I'm going to pose it. Thank you.
To me?
Yeah. So you showed 3 cases. I think the idea was that all of them were complex diabetics. One was a tractional retinal detachments. All 3 were monoocular. 2 were premacular bleeds. And patients were systemically unstable, sick. Had nephropathy. 2 of them were on renal dialysis. And all of them on post-op day 1 had fibrin in the AC, fibrin in the vitreous. One of the patients had fibrin underneath the retina. 2 of the patients on the ultra-wide field photo showed peripheral choroidal detachments and exudative detachment in the macula. Now, one was managed with re-surgery with oil. One was managed just with topicals, watchful observation, and getting the patient's systemic status. And of course, they were already on renal dialysis, but ensuring it was done because surgery is also a stressor. The third was, managed with topicals. And once the response wasn't as prompt as you would want it, it was augmented with a posterior subtenon injection, and that got it better. Now that you, have shown us the spectrum, if you were to revisit these, what would be your take? If you get this on post-op day one, how would you say, what is the best way to manage these?
I think the first case, I did not think of PST. He was monocular, and I think when I was operating, the vitreous hemorrhage was very, very dense. You know, the yellow chicken fat kind of a thing. And of course, there was a peripheral skirt where you cannot do base shaving. And of course, there was thorough laser. So I was thinking more on those lines, and I didn't want it to give a depot of steroid in the posterior subtenon space. So probably next time I'll think of a PST in such cases, and probably see with that rather than just going and operating on the fifth day. So that's my understanding from both your cases that I'll try that.
Well, fair enough. Anybody else has to add anything to that?
Are you using anything from the formalin chamber in your OT? Are you using anything from the formalin chamber in your OT?
No, no.
First, okay.
No, we don't have formalin.
Second thing is that what I have observed that whenever we leave BSS or any simple fluid, then we have these kind of cases. If we are using the FAE or any tamponade, then most of the time we don't see or never we see. Somehow it has linked with that fluid. The BSS we leave, the simple fluid we leave, we have these kind of things.
Yeah. My only thing is we do a lot of these cases. We do leave saline, and I've never had this. I've just been two cases.
These are
and
rare.
Sometimes I've seen them at the interface of the air and the inferior
Interface.
saline. Even there I've seen at that interface there was the web.
This is my point, that
Yes.
whenever we leave, see it always happens with the fluid only. It never happens with the tamponade.
Yeah.
Or maybe we don't see it with the air in the eye. Yeah. Raman's point.
I think,
Point taken, sir.
I've seen a lot of these cases with Professor Mohgupta sir also there, but we generally saw in bad patients, nephropathy patient, it happens. But what works was, sir used to say, was subconscious DEXA used to work. Nowadays we don't give it. I think
Absolutely, sir. And just to round off the discussion, and I think on post-op day one, a diabetic vitrectomy, a complex one at that, membranes have been removed, or you've done a lot of premacular, your hyaloid removal, blood removal. You get fluid in the macula. You see fluid. I think three things come to mind. One is a regma, which you did not notice, and that happened. Although you'd be struggling to come up with a case from your recollection, where on post-op day one, even if you had a break which you did not detect, you have a RD in a diabetic case. But that is one. The second is there is low pressure. Either it was not sutured, that caused the choroidals and all of that. The third is endophthalmitis, because post vitrectomy presentation of endophthalmitis would be different from let's say post cataract. The fourth one, which is unique to these systemically unstable, rather sick patients, and as Raman sir pointed out rightly, patients with chronic renal failure on renal dialysis, because their body has a lot of fluid overload, it can't excrete a lot of stuff. They are generally on renal dialysis. Coupled with that, surgery is a added stressor for them that puts the whole system, gives the whole system sends the whole system for a toss. And the idea is, if they're on twice weekly or thrice weekly dialysis, to have a dialogue beforehand. This is what I've been doing, that they have to have their next schedule of the dialysis a day after the surgery, because that ensures that a lot of the fluid which is retained in the body goes out. Their systemic parameters get better, because no matter how good they are, once they undergo surgery, and mind you, eye surgery might feel like kya ho gaya, body mein kya farak padega, it's a stressor. Patient has received a local block, might be under general anesthesia. The whole body, the system of these already fragile patients goes for a kind of water retention, catecholamine release phenomenon. So you have to ensure they get renal dialysis. The next day, most of them, if not all, will resolve without having to resort to surgery. Topical steroids and oblique or periocular steroids is the way to go. But of course, one has to rule out hypotony, because if that's the cause, then there is a separate kettle of fish. So intraocular pressures are very important to be looked at. And endophthalmitis is something post-PPV, thankfully rare, but you have to ensure that it doesn't come back to bite you. So if there is hypopion is something that will never be there in these patients, even if there's a lot of fibrin. So then your antennas have to be up. But the idea is the toxic posterior segment syndrome in sick diabetics with CKD, please manage closely, conservatively, and most, if not all, will do fine conservatively, but topicals may be augmented.